Awesome. Okay. Hi, everybody. I'm Jessie Roth. I'm the co-director of the Institute for the Development of Human Arts. I'm just going to give you a couple of quick intro slides here before we kick off the discussion. Thank you so much, everybody, for joining us. We have been really blown away by the response to this event. And yeah, we're honored to have, I think, close to 1,000 people joining us. And I wanted to start by just doing a quick visual description of myself. I am a white woman with brown hair, have my hair in a bun, wearing headphones, and I'm sitting with a couple of my houseplants behind me. So welcome to Decarcerating Care, taking policing out of mental health crisis response. And yeah, just to tell you a little bit about the Institute to kick ourselves off here. We are a community of current and prior mental health service users and survivors, psychiatrists, psychologists, and other clinicians, as well as activists and artists who have all come together with the goal of transforming mental health care. And we do this through collaborative education and community development through events like this, with the goal of advancing critical, effective, and scalable alternative approaches to mental health. And what makes IDHA unique is the way that we integrate both experiential knowledge and academic knowledge to challenge the idea that only those who work in the field of mental health or as professionals are the experts, with the goal of shifting power dynamics that traditionally privileges professional experience. And there's an image on the screen here of one of our members, Angel Serrano, giving a speech at a conference for peer specialists in New York City. A couple of community agreements for this evening. The first is shared expertise and wisdom. So we acknowledge that everyone brings their own expertise to this conversation and that we can all gain from and respect each other's various expertise. The second is collective liberation. So overcoming oppression aids everyone's liberation. It's our responsibility to challenge various forms of prejudice. We educate in the spirit of solidarity and hold each other accountable without criticizing who we are as people. And finally, we listen like allies. We respect a wide diversity of choices and perspectives, even when we disagree, and we don't judge or invalidate anybody else's experience. So a couple of quick notes on accessibility. We do have closed captioning available. So in your webinar view, you can click the closed caption button. There's a screenshot to show you where that's located. We also are joined by 2 ASL interpreters, Andrew and L'Oreal, who will be swapping out throughout the event. And finally, wherever possible, we aim to provide visual descriptions, like I did at the beginning, and I'll leave a moment to let our ASL interpreters do that as well.
Hey, Jessie, just really quick, this is Andrew, one of the ASL interpreters. I'm seeing a lot of comments that are saying that the ASL interpreter is actually not visible currently. And I have explained how to pin it on some people's side, but a lot of people are saying they can't see it. So I'd just like to make sure we can double check that, please, before moving forward.
Yes, I can stop my screen for a moment to make sure. So, let's see. Yes. So people can see them now that I've stopped sharing my screen. I will just, to leave the interpreters visible, I will just read the last couple of quick notes. We're almost through the slides anyway. So the first is just that we are recording this event, as you can see, and we will share it with the registrants later. Please feel free to submit any questions you have for the panelists using the chat. You can also use that chat to share any of your thoughts and reactions. We likely won't be able to get to all of the questions this evening, but we will save the chat and hope to engage with the content on an ongoing basis. So the way that tonight will work is I'm about to pass it over to our moderator for the evening, Noah Gokul, an IDHA member and your moderator for the evening. And then we'll hear from our amazing panelists and dive into a discussion. So once again, thanks so much, everybody, for joining us, and over to you.
Thank you so much, Jessie. And wow, we are at 1,000 people, y'all. That feels very historic. So my name is Noah Gokul. I use he, him pronouns. I'm a young brown man of Indo-Caribbean and white descent, wearing a white shirt a black shirt and a white turtleneck underneath. And my hair is up in a bun, and I have a green bun. And behind me, I have artwork and a keyboard. Wow, I really want to welcome everyone to our event, Decarcerating Care, taking policing out of mental health care. It's such an honor to moderate this panel of such terrific folks. I want to thank all of the folks, particularly all the IDHA folks, particularly all of the co-organizers of this event, Sasha DeBrule, Jesse Roth. We put a lot of love, time, and energy into this event to make this happen. And I really want to thank our esteemed panelists who are giving us a range of perspectives on how to create community-based alternatives to cops. So I'm just going to read a little bit about our event and ground us. Having this range of perspectives and embracing complexity aligns with the intentions of IDHA. I want you to know that people who put this event together are coming from a place of love and care for our communities, care for ourselves, and care for our world. And part of that care looks like justice for those who have not been cared for, and it looks like transformation of what care looks like. Taking policing out of mental health crisis response means understanding that the mental health care system has its own form of policing people's bodies and minds, and it has been used to exert control over Black bodies, not unlike the prison system. Caring for distressed individuals is not handcuffing people and putting them in hospitals and other confined spaces and labeling them disordered. I'm sitting here in Portland, Oregon right now, a town filled with smoke from increasing wildfires, rampant police violence on protesters, in the middle of an epidemic with so many struggling people. So we have to be really clear that crisis is way more complex than a disease or disorder, and a people in crisis reflect a world that is in crisis. We are deeply inspired by the Black Lives Matter movement and the subsequent calls to defund the police. Within the conversation of reallocating funds toward mental health, there are a ton of people and experiences that are so often left out. And those who know the carceral nature of our mental health care system. And today we bring in some of those voices. So I'll just have our panelists introduce themselves. I'm really, really excited to have them on this. I'm gonna start off with Stephanie, who's a really brilliant mind in this topic. And then we'll go in order of Stephanie, Asantewa, Tim, Stella, and then Neil. So I'll just let Stephanie join us, and thank you all for joining.
Thank you, Noah. Hi, everyone. Thank you for being here. My name is Stephanie. I use she, they pronouns. And for a visual description, I'm a white femme-ish presenting person with dark blonde hair, some facial piercings, and I have a blue t-shirt on that says "The future is accessible," my favorite. A little bit about me. I am a queer, genderqueer, disabled, mad, autistic, neurodivergent, psych survivor with lived experience of psychiatric incarceration, specifically for the purposes of this panel. So coming to this really as a peer, someone who is providing support and advocacy services for others, but also having that same lived experience myself. Some of y'all also may know me from Project Let's, the director of Project Let's, and we are a national grassroots organization led by and for folks who have lived experience with what is called mental illness, madness, disability, trauma, and neurodivergence. And our focus at Project Let's is really building transformative peer support collectives and community mental health care structures that really exist outside of and do not depend on state-sanctioned systems of, quote, care, which we know really replicate a lot of the very violent aspects of the prison industrial complex and are really trapping our folks inside of these systems that are meant to cage and kill us. So really working with multiply marginalized folks and communities to provide access, political education, and the material resources that we need to survive and thrive. And for me, I'm really excited to be here in this conversation today. Personally, I've had a lot of lived experiences with the conflation of treatment and punishment, which I think we'll talk about today, and the just pathologization of very logical responses to harm and to violence and to things that are happening in our world that then become disordered within us. And I think a lot of our panelists have a lot of similar experiences with that. So I'm excited to talk about that, as well as some pretty harmful experiences, losing my, bodily autonomy and my self-determination. I've experienced police brutality, and as I mentioned, incarceration and forced medication. So I am really committed and dedicated to building these alternative systems that are based in mutuality and respect. And excited to hear my brilliant, badass panelists talk about all of this more today. So I will pass it on to the next person. Thank y'all for having me, and thanks to IDHA for organizing this event.
Hello, my name is Santawa, pronouns she, her, hers. I am the daughter of Valerie Boykin and the granddaughter of Bertha Brandy. I am wearing a gray shirt and some really neat Bantu knots in my hair. I'm also one of the co-founders of the Anti-Police Terror Project and a founder of Mental Health First, which is a mobile crisis response team that is independent of police. I hope what I can bring to the conversation is the introduction of new ideas around what these systems look like. I think our job now is to divest from the systems that don't serve us while simultaneously building our own systems. So I hope to bring those ideas here to this table. I'm also an ER nurse, and I've worked in inpatient psychiatric care for a decade or more.
Excuse me. My name's Tim. I use he, him, his pronouns. I am a white male wearing some glasses. I've got a brown and black plaid shirt on, and behind me is a white wall with some framed pictures and a couple of jackets hanging up. I came to work with the Cahoots Mobile Crisis Response Program in Eugene, Oregon in 2010, where I served as a crisis worker for about 5 years before transitioning to a role as the administrator of the program. And in addition to the work in the field as part of that mobile crisis response, I also have several family members who have been touched by substance use and abuse, as well as mental health. I myself have, coming today to this conversation with lived experience, specifically around PTSD. This is a really exciting opportunity to engage in a conversation, with a lot of different perspectives, and similar and different to Asantewa. Cahoots is a mobile crisis program. But we are integrated into that public safety system. So, I think that there's going to be some really, I'm just really excited to talk about it. I think that as we really look at what public safety means, without enforcement, we need to be looking at what are the types of first response that we can bring in that are going to be able to respond to crises, that are going to be able to respond to the underlying issues that allow that crisis to exist in a community. The way we've been approaching it, across the U.S. hasn't been working. And part of my work is I talk with cities across the U.S. about how they can really, transform their crisis response and really evaluate where, that fits in, whether that does work with existing systems or not, is just a tremendously powerful conversation to be having. So thanks for this opportunity tonight.
Thank you, Tim. Can we hear from Stella?
Hi, can folks hear me?
Yeah.
Cool. Hi, so my name is Stella Ekia-Mensah. My pronouns are she, her, hers, and I am a Chicago born peer support specialist, writer, artist, performer, transformative justice advocate, and psychiatric survivor. I am a Black, light-skinned, half-white woman with short brown hair and a green and red button-up in a room with many things on the wall behind me, colorful little items, and some yellow curtains. And I'm so thrilled to be here. This is extremely exciting. So a bit more about me. Like I said, I'm a peer support specialist. So I, at the moment, primarily work with homeless women in Boston. That's where I'm currently based. So I provide peer support-based advocacy, largely drawing on my experiences as a multiple trauma survivor, psychiatric survivor, a person who has briefly experienced homelessness actually immediately following my psychiatric incarceration some years back. And I also serve as an advocate for folks that I support as they navigate the very terrible carceral system that extends also to shelters, which I think is something that sometimes gets left out of the conversation, is the carceral nature of homeless shelters as well. My background largely in regards to peer support and my advocacy and activist work, that element of my life is largely in transformative justice. So I started a transformative justice initiative at Brown University, where I graduated in 2017. It was really, transformative justice was a very life-saving framework for me, and really is at the root of most of what I do and think about, and really to me is my sort of pathway to liberation. So in addition to those things, I'm like I mentioned, a writer and an artist at the intersection of memoir and political thought, as well as magical realism and other forms of creative writing. So in terms of being on this panel today, like I said, I'm a psychiatric survivor. This might be a term that some folks aren't familiar with. It's a word that I use and that a lot of folks use to describe themselves, indicating that I have survived psychiatric torture and abuse. And in my case, also sexual assault within psychiatric incarceration settings, forced drugging, various forms of torture. And I, as a result, am very personally attached to this cause, and truly, as an abolitionist, think that psychiatric abolition needs to be also at the center of our conversations, as I don't think that psychiatry and psychiatric abuse is really like a sister issue or system to police and prisons. I really think that actually it's more of a subcategory of police and prisons, and that all of these are examples of state control. And I'm really thrilled to be having this conversation. Thank you.
Thank you so much, Stella. And last but not least.
Oh, hi everybody. My name is Neil Gong. Thanks so much to IDA for having me, and for all of you for being here. This is such an important conversation we're having. So I use he, him pronouns for visual description. I'm an Asian American man with long black hair and a beard, wearing a maroon shirt set against a yellow wall behind me. I'm also showing off my face mask from the Michigan Graduate Employees Organization. The grad students are on strike right now. I'm sitting in solidarity with them. I'm a sociologist at the University of Michigan. And they're striking right now for both a healthy campus reopening and also a remaking of the campus's relationship with the police. So I'm an academic. I do research and I teach, and what I research is community mental health care and inequality. I'm currently writing a book that looks at intensive community mental health services for the rich and the poor in Los Angeles. What this means is I spend a lot of time shadowing case management teams, public mental health services, and the public safety net, and then looking on the other side of town at elite services for wealthy people and what that means. Another part of my research is on the history of psychiatric care in the United States, and specifically psychiatric deinstitutionalization. So how we went from a system that locked people up in state hospitals to one that often abandons vulnerable people to the streets or locks them up in jails. And this is probably what I'll mostly be focusing on today, and addressing some of the lessons that that history holds for our current moment. Because that's a history of activists and policymakers successfully defunding an oppressive system, but not actually getting the promised reinvestment in community resources and care. And so I think this is very important for us to think through and think with as we try to remake systems today, alerting us both to opportunities and some pitfalls as we work to reallocate police funding. I have a recent piece on this, and it's linked on the webpage, called How Defunding Abusive Institutions Goes Wrong and How We Can Do It Right. It's in the LA Review of Books. And I came to this work mostly because of some of the bad experiences friends and family had with mental health care, either being ignored and not having access to care, or on the other hand, getting treatment that messed people over more. And so for a long time, I thought my role in this would be becoming a clinician. After college, I worked for a brief time on a community mental health and housing team in New York City. And I was just continually amazed at how broken the system was. And I had all these questions. Like, why were so many people with psychiatric disabilities precariously housed or coming off of the streets? Why were so many people locked up in jail? And how did we get here? And part of this I'd already been questioning after working with the Icarus Project. The Icarus Project was a radical peer-based mental health support network, and they exposed me to ideas from the Mad Pride movement, psychiatric survival movement, and other attempts to really rethink what it is we're talking about when we talk about mental illness or madness or psychiatric disability. And between these experiences working in this broken public system and working with groups like the Icarus Project, I realized I was more interested in and better suited to try to address these more systems level kind of issues than becoming a therapist. And so that's how I ended up as a sociologist working on these issues. And so as I mentioned today, I'll be mostly be talking about the historical roots of some policy failures related to deinstitutionalization and then how that might inform what we do today. Yeah, glad to be here.
Thank you so much, Neil. And just thank you to all our panelists. You know, I really just want to highlight again the diverse perspectives everybody's coming with here, that really is going to, you know, show the complexity of the topic that we are talking about today. So I just want to get into it and start with this first question. And this, you know, this is a question that, you know, I've been on webinars that are on this topic of replacing mental health care with instead of cops. And so, you know, what we're going to do is really identify with the question, what's left out of the mainstream narrative about social workers replacing cops? Like, what is left out of this conversation when we talk about this? You know, and I'm definitely calling on, you know, Stephanie, Stella, and Neil, who, you know, might have thought about this question and really might have some interesting things to share. So feel free to jump in, whoever wants to start.
Hi, this is Stella speaking. If it's all right if I jump in. So as a neurodivergent abolitionist, I fundamentally think that when we talk about the evolution away from police involvement in mental health crisis response, I think fundamentally we really need to accept, before like any other work that we can do to really transform what's happening, we need to accept the histories of psychiatry and social work as tools of social control. And so I think it's so important for us to educate ourselves and each other and challenge ourselves and each other to see that, you know, that's not really a reductive way to describe psychiatry and social work. Honestly, like if we look at diagnoses like drapetomania, I've never known how to say that out loud. Basically, it was a diagnosis in antebellum slavery to describe Black enslaved folks who wanted to run away. So it's a diagnosis, you know, explaining what the mental disease that was quote unquote going on that could possibly compel a Black enslaved person to want to run away from their torture camp. And I think it's important also for us to keep in mind, like, that was not that long ago. And I think we often do this thing in our culture and in systems of mental health, and also just in how we like view the world and view like healthcare, where we're like, okay, there was the period, like that was a long time ago. There was the period of the asylum, and then there's now, and these are like utterly separate eras and periods of time. And I think we really need to, like, when we think about psychiatry, look back to those kinds of diagnoses and understand that like the foundation of something is extremely relevant to its current functioning. Like, it is just inextricably relevant. Not only relevant, it is like fundamental. So, and then if we think about like the torturous nature of the asylum, which is something I think like we all can pretty much get on the same page about, and then, you know, bring it to the present and think about like the mounds of anecdotal and quantitative evidence about people's current experiences, both on psych wards and in appointment-based relationships with social workers and other therapists, we can see that there is a base level desire to control, correct, that's a big one, drug, discard, and even torture those at the bottom of the social hierarchies created by white supremacy and colonialism. And the elements of torture, correction, you know, drugging, discarding, they're not like accidental byproducts or incidental, you know, byproducts of, you know, or casualties, I guess, accidents within attempts to care. Like, they are really, I think it's important for us to challenge ourselves to see like, well, maybe this is at the core of like the intention of these systems. So that I think when we accept that like this is not only our history, but our current reality, like the asylum is not dead. There are tons of us, myself included, psychiatric survivors who experience torture on psych wards that is akin to the torture experienced in asylums. And it's really, yeah, I wish that I could say that we were beyond that, but we just are not. And I think it's valid for folks who've had good experiences on psych wards to describe those experiences in their own language, and that's like very necessary and vital. And I also think like we need to prioritize these stories. And so, yeah, if we accept that this is our current reality, we can see that psychiatrists and those who are in alignment with psychiatry are police officers of a, you know, a slightly different form. And I think something that's helpful in seeing how this is the case is thinking about like how we're now addressing systemic racism and white guilt in the mainstream, because I think this is something that's like a tiny bit more accessible to folks now at the current moment, given the uprising that is occurring, you know, that is very vital and, you know, inevitable. If people can accept, and I'm seeing a lot of people around me accepting that even though antebellum slavery happened a long time ago, kind of, not that long ago, but happened, you know, a significant amount of time ago, its ramifications are still rampant systemically and in like our psyches, especially in the psyches of white people, in a way that requires like ongoing lifelong work, then I don't see why we can't extend that same logic to the reality that psychiatry's torturous and eugenicist roots are still systemically rampant and present in our psyches in a way that requires ongoing lifelong work to unlearn and dismantle. And I think that culturally we make a lot of excuses and qualifications for like psychiatric quote unquote treatment as opposed to something like systemic racism. And I think we really need to understand that, like, or challenge ourselves to see that systemic ableism, you know, eugenics, asylum thinking it's in us systemically, it's in our psyches. We have to unlearn it. That takes like rigorous work in the same way that like white people unlearning like white supremacy that is internalized takes rigorous work. So just a note on that. And then coming back sort of to the question of social workers at its core being involved, I think that social workers, I don't think it's a stretch to say that social workers are already like a kind of a form of police. And that isn't to say that like there aren't good ones. And I think there's more potential for a social worker to do like good care work and dismantle the system from the inside than there is for a police officer. But I can already see how social workers coming in for mental health crisis response instead of cops will be like a slight step towards abolition at best, and at worst, like an ineffective kind of publicity stunt for the state and for state control. And I think there's an argument to be made for like social workers being crisis responders as like a brief evolution, a brief stage in the evolution towards the abolition of state control. But to pull that off, I think it would need to be like explicitly thought of as a stage and not like the end goal, not like our salvation. And I worry that won't happen because the nature of psychiatry and social workers like involves that state control element. So I'd rather bypass that altogether and go straight to the stage in which peer supporters are the crisis responders, which is happening. And I'm really excited to hear from Santua, Allison, Tim, Carla, as well as Steph and Neil a bit more about this topic. And I do want to just briefly say that I really believe that the abolition of state control needs to be a process and an evolution. And I think it's good for us to hold and honor, like, this is a huge task because systems of power and control and surveillance and like punishment of the bad and strange seem to have precedents that date back like fairly close to the beginning of human history. So like this is like intensely difficult and challenging work, and undoing something as old and fundamental to how our world and worldviews are organized as state control is like nothing short of apocalyptic. When I think of like apocalypse in kind of, I don't know, the fall of like the empire. And so looking to like Indigenous folks worldwide, but certainly Indigenous Americans, and some of the discourse that I've seen about how like colonialism and genocide were already the apocalypse for Indigenous folks, I sort of feel like it will take another apocalypse, in the form of like the fall of the empire, to create the kind of world I think we deserve to live in. So I just want to honor like the difficulty of this work. And I think it also, I do want to honor that this is a world that we need to look intensely to indigeneity to create, and its formation needs to be largely led by Indigenous people worldwide. So
I just want to jump in here and like, thank you so much. That was like a amazing grounding for like, I'm really looking forward to hearing from, you know, what other folks have to say, but thank you so much. Like that was amazing. And it feels like we're almost in that apocalyptic moment right now with the smoke and the COVID and everything. So other folks want to jump in on this? Stephanie?
Yeah, thanks, Noah. I just want to echo what Stella just said. Thank you for that. I think, you know, at its core, abolition, you know, it means no cages. It's not like, let's get rid of the prisons and the jails, but keep the psychiatric incarceration and the nursing homes and the group homes, right? Like, and the court ordered ECT, like we can't pick and choose here. It means that we are tearing it all down. And I think that when we're talking about abolition, we need to be very clear, right? We are not doing this work and embarking on this journey and this and working towards liberation only to shift from one system of policing to another, which is what really Stella just described. And I think for me, when I'm thinking about this question and in general, it's really what we really want to be doing is transforming our relationships to neurodivergence, right? To madness, to disability, to mental illness, whatever term you use. We are working to completely reimagine, right? A different approach. We want to do this differently, grounded in mutuality, in reciprocal respect, in equalizing power dynamics. So when I'm thinking about social workers replacing police and the mental health care system getting more involved in this carceral role, Stella said it best, like we already are, like it already is carceral. And I think we have to make that jump logically, right? So to be part of the carceral state, really for me, we are thinking about systems that are containing people, right? Taking away their locus of control, offering surveillance, isolating folks from their communities, limiting their freedom. And we know that the mental health care system works in collaboration and partnership with police. That's kind of a fundamental aspect of it. And we can even think about the similarities between incarceration in a prison, incarceration in a psychiatric facility, thinking about the limited access to outside and fresh air and sunlight, use of restraints, whether those are physical restraints or chemical restraints, the law enforcement transport aspect of it, the limited accountability, all of those aspects are mirrored in these systems. So that's kind of what I'm thinking about, as well as this wanting to make clear that we know that both prisons and psychiatric institutions and mental health care in general can produce disability, right? It can produce madness as a result of, as Stella mentioned, this trauma, thinking about isolation, solitary confinement, all of that. So as Stella and I have discussed a lot, can social workers do good in communities? Yes. But like the police, this is not about a few bad apples. It's about a really pervasive and the unrelenting nature of systemic racism, ableism, classism, and the upholding of white supremacy that we know is a foundation of social work. And we can look back at Indigenous families being torn apart, Black families being torn apart by social workers acting as this gatekeeper of who is meeting the standards and who isn't, and what that power looks like. So I think, as Stella mentioned, when you're talking about having a good experience with mental health care or psychiatric treatment, that's a privilege. What we're talking about is you having the privilege to have had that good experience, and we need to really be centering folks who have lived experience. So the last thing I want to say on this is that, it's not about, for me at least, abolishing mental health care, right? Like, we want people to get healing and have access to resources, but it needs to be informed. It needs to be voluntary and healing centered. So I really think about peer support as an abolitionist offering, right? We are going to build systems of care and support for each other, but we're not going to punish people. We're not caging people in distress, forcibly medicating them. This is about reciprocal, culturally respectful relationships that I believe, if we don't center peers in our responses to what we are trying to build now, we are just shifting one system of policing in for another.
Yes. And I just want to say that, like, a lot of the stuff that both of you just said, one of the things that really helped us ground this event was the article that both of you put out, Abolition Must Include Psychiatry. Such amazing frame for this event. So thank you. And Neil Gong, one of our participants and panelists, just put out an article recently called How Defunding Abusive Institutions Goes Wrong and How We Can Do It Right. So I'm just gonna, call on Neil. What do we leave out of this conversation when it comes to, replacing social workers with cops?
Vice versa. Yeah. So let me first just say I really appreciate what Stella and Stephanie had to say here, and I think really got at an important point that, this is, I think, one of the core points that gets left out is the way that social work and mental health care and psychiatry can essentially be policing. So I want to say a few things about that briefly before I turn to some of my main points. I'm absolutely on board with the critique of mainstream psychiatry, that its long history has always had an element, and this maybe would diverge, how fundamental it is to the enterprise of social control that can often be aligned with or directly is policing. At the same time, and this, and you both alluded to this, right? Like, in building something else, we still want people to have access to whatever tools can be useful for them. So to me, the reframe is maybe, what can we reappropriate from even a corrupt system? Are there things that we can still hold on to, the expertise, the experience, the things that have worked for people, and make sure that they have access to that in empowered, voluntary kinds of ways. So if a person wants access to a social worker to help them navigate whatever system is in front of them, or therapists of different sorts, or medication, we want them to have access to someone who can meet them in an egalitarian manner. And so one person I think of, like in psychiatry, Joanna Moncrieff, has this idea about how like people don't actually get informed consent, even when they think they are, because they're not given access to the full range of side effects, or the fact that very often doctors have no idea how certain meds work, or what kind of effect it's going to have on people. But you could imagine a kind of prescribing practice or social work practice that's much more aligned with those ideals of informed consent and it being voluntary. And so we have to figure out how to hold on to the tools that people have found useful, reappropriate them for a new system. And this question of how we do this, what the transition stages look like, how do you not get trapped in the transition stage? I mean, these are big questions, I think, for lots of different kinds of movements. So really important stuff to talk about. The things I want to talk about from this article that Noah mentioned are less about police versus social workers per se, but about this issue of systems change. And so what I'd like to do is take us through the last time we transformed a major social control institution through defunding, and what that meant for vulnerable people. And as Stella was saying, it's not as though people, the asylum disappeared, but in some sense it didn't. There are still all kinds of carceral spaces people are locked up in. But I'm going to focus on this moment. So psychiatric deinstitutionalization, it's a story on the one hand of civil liberties victories, but also movements getting co-opted and people being abandoned. And so when abolitionists talk about it's not just destroying, it's about actually rebuilding, one of the things with psychiatric institutionalization is we closed a lot of oppressive places, but didn't actually replace them with community services that were supposed to happen. So in the 1950s, the United States held more than 600,000 people in various forms of psychiatric confinement, deprived of fundamental rights, often locked away indefinitely. And as people have been noting, this is often bound up in racism, sexism, or ableism. So simply families not knowing how to contend with difference. And so activists wanted the closure of these kinds of oppressive state hospitals and then getting reinvestment into high quality community resources. But what we end up getting from politicians like Ronald Reagan was a closing of the state hospitals, but actually not getting that reinvestment in the community. And we have to remember that very often politicians are not going to close something down, in this instance, because they believe in liberation for people. It's because it's a way to cut budgets, to not have to spend money. State hospitals were expensive. And then given related Reagan era cuts to public housing, to other forms of welfare services, a lot of people ended up being released to the streets. And later on, in many cases, people who are having crisis are going to end up being picked up by police, which is, of course, the topic we're focused on today. So if I restate that as something of a lesson for us today, it's that defunding campaigns can be co-opted and essentially turn into a form of austerity politics by people who just don't want to pay taxes. And this isn't to blame what happened with the institutionalization on activists, but it's a warning, because we're in a fiscal crisis right now, a pandemic-driven fiscal crisis. And we may see something similar, where we get access to cuts to police and prison budgets, but this is coming primarily from fiscal constraints. And we'll never actually see that community reinvestment unless we hold people's feet to the fire. So the priority really has to be on investing and coming up with alternatives. So defunding alone is at best a half victory, and it can even be detrimental. And here's what I mean. So another part of the story of deinstitutionalization is that there was quite a bit of backlash. So in the 1980s, as we're seeing more and more people with psychiatric disabilities on the streets or in jails, the public starts blaming this on deinstitutionalization, even though what's really at play is these further cuts to the welfare state and the rise of things like broken windows policing. But people end up, there's this phrase, people are dying with their rights on, they should never have been released. We need to bring back the asylum. And so to restate this one as something of a lesson for today is that failures in systems change can be attributed to botched reform ideas and efforts rather than underfunding, when it's really the underfunding that's causing this. And so today, we're in this pandemic-ravaged economy, and that means there's likely going to be a spike in economic-related crimes because people are trying to survive. It means it's likely we're going to see a spike in mental health crisis. And the risk is that the public is going to blame this on, say, we actually defund police, but don't come up with a system to deal with all of the pain and suffering people are going through. The risk is that the public's going to blame this on activists and defunding the police, rather than the societal conditions that are really driving what's happening. And this is actually already a sort of Trumpian rhetorical strategy you're seeing. So this is the danger of what happens if you defund without sufficient reinvestment to actually tackle social problems at their roots, is that it could bring us such a strong backlash that you hear people saying, no, we need mass incarceration. We need more police than ever. So concretely, that means we have to prepare for problems with new systems we build, especially in a bad economy like this. And we have to have real answers if people do demand a return to harsh enforcement. So those are two things I'd like us to keep in mind as we envision how we make this alternative system.
Yeah, thank you, Neil. And I think that your perspective really, it adds that really like such a good foundation, you know, and bringing in that history. And so I really appreciate it. And, you know, I think that from hearing from the three panelists that we've had, it's clear that it's bigger than just, you know, bringing in social workers, right? And it's bigger than, you know, just kind of having just immediate crisis response. And that there's so many historical reasons why, you know, we really need to find out a complex, you know, solution for these problems. And, you know, so I really want to bring in, you know, what are people doing right now to create alternatives? Because I think that's, you know, that's a huge part of this conversation. So, you know, in having this conversation of defunding the police and reallocating that money to alternatives, with us today are two panelists who represent alternatives to police and mental health crisis response. So what do these programs look like? So I'm going to pass the baton over to Asante and Tim. Either one of you want to talk about your programs.
Thank you. Thank you. Oh, my husband just brought me coffee. God bless him. So we created Mental Health First, and I like to kind of start off with this. Is it really just, and I think it probably exists in a lot of our communities organically, where those of us who historically are mistrusting of police and policing, we tend to create our own even underground, right, for lack of better term, systems where we just we agree to take care of each other, right? So we began to ask ourselves the question, why can't we build out something similar to what exists organically in our own communities and make it available to the larger community, right? Hence, this is how we came up with Mental Health First. And we'll begin to build the framework because we're not the first folks, right, to think outside of the box, to think outside of the current medical industrial complex or the psychiatric industrial complex, right? So we're not the first to do it, but we definitely wanted to do it in a way where there was absolutely no police involvement, because the folks that we were trying to capture were folks that historically are mistrusting of police or policing. Though we knew that at some point, the safety question would have to be answered. And I'm recalling the first question around, like, what do social worker models look like? I had a recent experience where some folks that were in Dallas were really asking us some questions like, how do we build this out? What do we do? And at the end of the day, they added an EMT to their team. They had a social worker, right? But also the social workers were echoing back to the city saying that, like, we don't feel safe responding, so we still need an officer like on our team. So I would just say, these social worker models still have to be divorced from police and policing. So if they're the type of social worker that doesn't feel safe approaching someone who may not be in our shared reality, then quite frankly, they're probably in the wrong profession. Here in Sacramento, we have a social worker that essentially wears a police uniform that has the word social worker on the back. So we can't incorporate social work in a way that's like, oh, look, we have social workers, but then those social workers are essentially police. And when someone who's not experienced our shared reality or has this like historical mistrust of police or policing, I can't tell the difference between one person wearing a bulletproof vest and another person wearing a bulletproof vest. So essentially they all look like police, right? Which is gonna escalate the situation no matter how you look at it. I think anyone who is having thoughts around how do we create something different, I would just say, look at the frameworks that already exist. Look at the places like Cahoose that have longevity and have been successful, right, in creating these programs and also influence other programs around the country and in some ways including ours, right? look at what's already being done. Look at the demographics of your city. Look at the high utilizer, right, list, if there's one available, and what are those folks lacking, and try to answer those questions. I think the first thing that we did as a team, once we kind of assembled ourselves, we just, hey, what could we build like if money was endless, right? And we called it our dreaming session. And then we kind of had to taper it down and go back to, okay, so what is accessible to us right now in this moment? And mental health first is what we built. I think our framework is super simple. Our primary goal is just to mitigate the immediate crisis and hopefully help that person come to their own next step, right? Our framework doesn't swoop in and tell people what they need or how they need it. We call it self-determined crisis management, right? Think simple as just getting a person from one place to another. This place where they feel unsafe to this place where they feel safe, right? And if that safe place is in an emergency room, then we soft hand off to an emergency room. If that next safe place is their sister's house, then we take them to their sister's house, right? And then if they want to, we'll call them back. If not, we tell them, call us back when you feel the need. I recall an instance a couple weeks ago where there was a person who had called us and was just like looking to get literally from like one place to another, and that next safe place for him was an emergency room. And I'll never forget this sentence. He said, if I call 911, they'll fuck me up. And that resonates, because when these are the folks that are supposed to keep you safe, get you the help that you need, so that you can get the healthcare, right? When there's a hesitancy in anyone's process because they feel that they may be harmed, it speaks to where we really are, right? We can talk about it. We can defund the police. We can say, right, this is what we need, abolition, 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 but we have to be really, really clear about where we are in this moment and who are the folks that need the services the most. And if we still have an existence where someone feels like if they call 911, and not just police, right, literally EMS, I work in an ER, and not to down those folks, but some of the privileges that exist amongst the culture of first responders is disgusting. I wish I could like explain or give examples without, really violating HIPAA or, down talking firefighters, EMS. But sometimes I have, in the ER, I've seen people treated so inhumanely that I wonder if we have really lost our souls, like as an entire species. Just because of the way someone presents, whether that be their skin color, because they're obviously unhoused, or because perhaps we know that they're under the influence. So we not only have to change the culture like in mental health specifically, but also actively working at changing the culture inside of our healthcare system. And then also with the understanding that these systems were not built for us. These systems were built for white land owning males. And that what we're really going to have to do is just deconstruct them and build them absent of the roots that are, steeped in white supremacy.
I think Asante touches on something that's really vital to what we're talking about here, and that's that crisis emerges when a need goes unmet. Whether that need is safety, getting a bandage change, getting connected to treatment services, a sense of community, whatever it is, there's a need that's going on. And when we can't meet that need, when we can't overcome those barriers that are imposed on us by others, that's when that crisis emerges. And, in Eugene and Springfield, we've been approaching our mobile crisis response in a similar, but different way. The CAHOOTS program, CAHOOTS is an acronym. It stands for Crisis Assistance Helping Out on the Streets. We have our mobile crisis response program sends out teams where you have an EMT alongside a crisis worker. We don't use clinical social workers. We don't recruit folks who have that higher level of credentialing, because we're not going out there and placing holds on folks. We're not doing diagnostic work in the field. It would be honestly a dismissal of the person and the experience that they're having to try and engage in any sort of diagnostic work in that moment. And so, as we kind of talk about how can these program, how can you have a first responder system that's actually going out there and really responding to the underlying issues related to that crisis, rather than approaching from enforcement, like you see with traditional infrastructure in the form of police departments. I think that the CAHOOTS model presents an opportunity to really talk about, kind of the whole system, not just mental health or medicine, but really looking at that intersection of those two things. By bringing in that EMT into our response, we're able to do a lot of work around harm reduction. We're able to open the door for folks who, maybe they don't feel comfortable saying, maybe they don't have the vocabulary to say that I've been experiencing depression for the last 6 months. But if they know they can reach out to the EMT and say, my stomach's been hurting, I've been feeling a loss of appetite, I can't hold stuff down, we start to open that door and find ways for people to come in and engage in a conversation that feels accessible and feels safe to them. Really, I guess I'll just kind of make sure that we're all on the same page, right? Because, some folks can go Google and learn about CAHOOTS, and I think it would be remiss if I just assumed that everybody had the same experience and background that I do. So CAHOOTS program in Eugene and Springfield, like I said, we have an EMT and a crisis worker that are paired together for our crisis responses. We have 24/7 coverage in our metro area, which has about 250,000 folks. And all of our calls for service, every request that's made of CAHOOTS comes through the traditional public safety system. That means that the point of access for CAHOOTS is to call the public safety non-emergency number, because we're not an emergency ambulance service. That means that CAHOOTS crews are being dispatched over the same priority channels in public safety as patrol, as the police. That means that our unarmed civilian first responders who are going out without pepper spray, without tasers, without a vest on, wearing a t-shirt and hoodie, driving a vehicle that looks nothing like traditional public safety apparatus. That means that, all of our calls are being broadcast on that system where, officers are hearing where our teams are going. And to address that kind of that perception of how unsafe these responses can be, we view that radio as kind of part of our system of safety, and that's that resource we can reach out to in those moments where things do escalate beyond our ability to control. But those situations are very rare. We had 24,000 calls for service last year and only needed to call for support 300 times. That's 300 times where there was something either, because somebody was going through something so profound that we needed some extra support to maintain their safety and the safety of others. And rare situations that resulted in a hold to get somebody to the hospital because we really needed to utilize those traditional systems to get that person into a better place in the moment. We're able to divert thousands of calls from police contact each year. And a lot of that has to do with having a system that's really been developed for the CAHOOTS response system that's been developed to really respond to all manner of situations, not just mental health presentations, not just suicidal subjects, but when somebody calls and says, I don't have any place to go tonight, CAHOOTS is who's going out to talk to them. When somebody calls and says, there's this person sleeping, in the doorway of my business, it's CAHOOTS coming out to try and get that person connected to services rather than to enforce a trespass order. And so as we kind of talk about all these different, alternatives, all these different options, I think that Stella put it really well, that we're in this transitional moment. And right now, this system of using that dispatch, of using those traditional public safety tools as our point of access for CAHOOTS is a step in the right direction. But even within our own community, we're seeing that using that public safety non-emergency number means that we're only available to folks who feel comfortable, who feel like it's safe for them to call and request our services through that public safety system. And so as we engage with our partners in this process, and that includes law enforcement, that includes EMS and the fire department, one of the things that we're really prioritizing right now is how can we make ourselves more accessible? Is it going to continue to serve us to be a part of that traditional system of dispatch? Or can we accomplish the same kind of outcomes that we have without reliance on that system? And I think, the last thing I really just want to highlight is that, we're really trying to work ourselves out of a job here. I think if you talk to anybody on the CAHOOTS team, we don't want this to be a needed service in another 30 years. If a community is able to apply restorative justice, community mediation, violence interruption, decriminalize homelessness and drug use, if we're able to provide compassionate and adequate voluntary resources for folks, we envision ourselves getting to a place where this just isn't a necessary service. That's our goal. That's, ultimately what we're trying to do is really get to a point where you don't need cahoots anymore. But we also are trying to be grounded and realistic and recognize that we're not going to get there tomorrow.
Thank you, Tim. And we have an audience question, and I think that both of you who just answered might be good folks to talk about this question. So someone had a question: how do we address liability concerns for mental health providers and community organizations might endure when they are responsible for meeting the needs of persons experiencing mental health emergencies? What supports are needed for these organizations to not rely on law enforcement as a safety net?
On one level, it starts by just really looking at how you're talking to folks. Really, again, 24,000 calls for service last year, and we only ran into situations we couldn't de-escalate 300 times. That says that by and large, these unarmed civilian first responders are going out and having a lot more successful, a lot safer interactions than counterparts with guns, badges, with the tools of enforcement at their disposal. And so I think in that communication, it's not just using the right words, right? It's not just being mindful of pronouns or holding space for somebody. It's really recognizing how much cumulative neural fatigue there goes into meeting your basic needs and addressing anything that you have going on a deeper level. It's really recognizing how the direction of the wind, what the weather's been like for the last few days can inform how this person in the camp is going to respond to you. And really, again, looking at the whole person, looking at how physical health informs behavioral health and vice versa, how the culture and the systems that we've grown up in inform how we interact moving forward. And there is this constant perception of danger, and that liability is our biggest concern. And I really have to answer, why is it that as soon as we start to talk about a different type of response, there's this perception of danger, this perception of othering, and instead of really looking at through the lens of these are our neighbors that we're trying to support, it's always there's this other thing out there, this unknown entity, and because I don't understand it, it's unsafe. I think if we can start to really give providers opportunities to really hear more of that firsthand, that lived experience, if we can provide opportunities for peer support workers, for folks with lived experience to be the providers by, identifying non-traditional approaches, then I think we can start to steer the conversation away from liability, because that's where's the conversation and liability for every traffic stop, that police are engaging in. We're not having conversations about liability insurance related to, the use of chokeholds. So why is it that we have to talk about liability before we can start to talk about first responder reform?
I'd really like to echo what Tim said around making sure that it's peers, right? Not just responding, but also creating the best practices. I think that it takes a lot more than a degree, right? And something to say, oh, this is how this should work. I know MH First, we have a peer council, folks that have had all kinds of interactions with the healthcare system, with mental health care system, and also with police and policing, informing what our best practices look like. So I think that would be step one. We really have to listen to the folks that have the lived experience. And then I also think we have to go about, and I don't like the term destigmatize, right? I think we really have to normalize, right? These things that naturally exist in our communities. We have to normalize someone who may not be in a shared reality as us, right? We have to normalize folks that are dealing with depression, because I think currently the way our system is set up is when these folks are not behaving in quote normally, they can just be disappeared, right? There's a number to be called and they can be disappeared, and then we don't have to look at them anymore, right? That should definitely not be the case. And I think as we move about and we start to create like non-medical industrial complex, non-police responses, that I hope that folks just get more comfortable with dealing with our neighbors, right? We've looked at just 911 call databases in Sacramento, and not 50% of the calls are needing police, are folks, hi Siri, I saw your comment, hey boo. So I'm sorry. So under 50% of the people, under 50% of the calls actually need police, right? So how are we going to continue to organize the police out of these spaces, right? And I think a lot of it is just encouraging folks to talk to their neighbors, no matter how they come, because a lot of the calls are neighbor disputes, noise complaints, mental health calls, right? So we have to shift from needing this person with a gun to mediate our conflicts and helping us disappear our neighbors so we don't have to deal with them, and really encourage folks to begin to have conversations, just period across the board.
You know, this reminds me of something that happens on Cahoots a lot. So one of the types of calls that Cahoots will respond to are welfare checks for a subject down. That's somebody who's not up and walking. It could be that they're taking a seat, resting their feet. It could be that they're trying to just get some shut-eye after being up all night, trying to find a safe place to be. Very frequently, these calls will come in, you know, one caller unable to confirm whether or not they're conscious and breathing. And what that says is this person saw something, thought, hey, I should call so that issue can be, as Asante said, disappeared. But they're not even willing to take the steps necessary, the literal steps necessary to get close enough to see whether that person that they're so concerned about that they're going to call and have resources go out to, they're not actually willing to take the literal steps to get close enough to see that that person is breathing, to determine whether this is a medical emergency or not. You know, let alone, hey, you know, what's your name? How are you doing? Do you need anything? So it's a lot of this is about, I think, you know, obviously white fragility, being unwilling to really recognize that we live in a broken system, but really this disconnect from our neighbors, you know, this disconnect from our community. And when we start to have those conversations, when we start to engage with people, when you learn the name of that person who's living in the tent around the corner from you, then it's not just, oh, that problem needs to get disappeared. It's that, hey, Joe's really struggling today. You know, we need to really be able to build those connections. It's the relationships that we have with our neighbors and with our community that are going to empower us to make any sort of real, you know, meaningful, lasting change.
I know we have like good Samaritan laws, but I'm wondering, and this is like way to joke, like, do we need bad Samaritan laws? Like, if you don't check, right? Like, don't call us until you check a pulse. You know what I mean? Like, don't call us until you say hi.
Yeah, I mean, that doesn't sound like, you know, a ridiculous thing at all to me. So thank you so much. No, I really want to, you know, I want to come back to this really like interesting conversation, and of course this is related, but I'm really interested in centering our conversation within the Black Lives Matter movement, you know, and how policing, crisis response, and psychiatry has an effect on Black folks. So the question I have is for everyone, and this is just to really name this, but what role does the larger Black Lives Matter movement play in the work that you're doing? And we have about 15 minutes for that. So just reminding folks that I'm going to be keeping time, and if you see me pop up on the screen, it means, all right, maybe 2 minutes left. I'll give you 2 minutes left. So yeah, what is this? What is the work that you're doing have to do with? What role does it have to play in the larger Black Lives Matter movement?
I'll jump in briefly. Yeah, I think it's impossible to separate the evolution towards abolition of psychiatric violence from the abolition of structures, white supremacist structures and white supremacy. Like I mentioned earlier, you know, I think the ways that Black people have always been pathologized in this country just for like having feelings, which of course like Black women experience more than anyone, Black trans women. There are so many intersections that like make particular folks like more and more vulnerable to abuse by these systems. But thinking about that book, The Protest Psychosis, which I think a lot of people look to as a great example of how Black folks historically just being resistant to systemic violence and protesting and being revolutionaries on any scale has been grounds for us to be considered psychotic. I think it's just like, it's very important for us to think about this looming threat of psychiatric incarceration if you're a Black person who is resisting the system. So not only are psychiatric cages vital to tear down, I think, in addition to, you know, more typical, I guess, prisons, largely because of how they mass incarcerate Black folks in this country. Also, there is the very present threat of Black folks, and this happens every day, and like, this is largely part of my experience of psychiatric harm. Yeah, just for resisting, we are considered psychotic. And I think not only that, but I think it's also important to think about how so much of the like divergent behavior that neurodivergent folks like myself, like I've exhibited at times, divergent behavior that like Black folks in this country like are often incarcerated for. First of all, what is it divergent from? Like, what is normal? And like, why is normal like defined by whiteness and like respectability and like palatability? But also, there are such logical experiences of divergence that come out of like so much inherited and ongoing trauma. And I think, so not only is it like absurd to label like Black resistance as like insane, it's also absurd for us not to take into account like how racial trauma and anti-Black trauma and white supremacy like create divergence that can get to the point of like distress and like pain. Not just divergence in the sense of like resistance, but also like, yeah, distress, and like it makes sense, and it's valid to respond to trauma by like not being respectable or palatable. So yeah, lots of kind of, scattered sort of thoughts about the intersection of Black Lives Matter with this topic.
I would say that one thing, this sentiment, I think the words Black Lives Matter is a phrase that I think most of us can get behind, right? I think that one of the biggest things that the Black Lives Matter movement is kind of centralize that messaging. Even though when we think about the Black Lives Matter movement, there's several like organizations across sectors, right? From grassroots to nonprofit to, you know, the whole gamut. And I think that what they've done is give us some centralized messaging that is palatable, right? Even to folks who don't have a taste for it, right? It's palatable. I think also what I've noticed is folks have been watching the patterns, right? What we understand is that I think it's somewhere around 70 to 75 folks who were murdered by police were those that were in the midst of a mental health crisis. I think that those similarities can't be ignored, right? So then folks begin to have these conversations, well, why is that? That's because the police are showing up and guns are showing up and not care, right? So then obviously these folks would subsequently be harmed at greater numbers, which is one of our goals, right? Is just to decrease police contact so that our folks are not murdered, right? Because if the police aren't showing up, then they can't shoot them. I would encourage that as folks, and I believe the media does a very, very poor job at really stating what is happening on the ground, and they use this blanket term, right? Black Lives Matter, and in one sense, it offers folks that are on the ground a certain amount of protection, right? And also it erases some of the work of folks that have been doing work for over decades, right? So it's kind of a double-edged sword, but I'm really excited to see that sentiment, right, of Black Lives Matter moving to defund the police, right? Now that we have the sentiment out of the way and we understand that Black lives in fact do matter, what are we going to do about it, right? We're going to defund the police, we're going to defend Black lives. So I'm really, really excited to see the sentiment move into something that is more of an action.
I'll just say briefly, the Movement for Black Lives has done such a phenomenal job of maintaining a very intersectional lens that brings people together, big tent, showing how various kinds of struggles are interconnected. But they've also shown that by centering Black lives and the needs of the most vulnerable, you end up with analyses and approaches to concrete change that will benefit everyone. Which is all to say, the fact that we're even talking about mental health system reform or transformation in the way we are right now for everybody is in large part because of BLM. And it's really exciting. Things are on the table that were not there before. Another thing I'd like to highlight that I'm so excited to see in this conversation, and we're working through a lot of it today, is trying to think in a very complex way about how race and criminalization play out. A lot of radical mental health spaces have traditionally been very white, and you end up with these sort of divides where people are maybe talking about one side of the carceral spectrum, which is institutionalization in psychiatric hospitals, whereas you have other folks, often from less advantaged communities, often people of color, specifically Black communities, where that's less the threat. It's more the threat of the jail cell. And those have, in some cases, been kind of separate conversations, and I think it's so important right now that that's coming together, and we're trying to figure out how to move forward with all of that. So.
Yeah, thanks for that, Neil. Just want to echo what folks have said and add a couple of thoughts, which is that, I really believe, if we're doing work around policing, crisis response, anything to do with mental health, we have to be centering the folks who are the most marginalized, the most targeted by systems of oppression and the violence at the hands of these, the medical system, prison industrial complex, et cetera, and really be thinking about how policing in and of itself, as Stella was mentioning, is impacting the psyches, the minds, the bodies of Black folks, how that creates trauma and creates disability, right? This is a non-negotiable, that as long as these institutions exist, that we will not be able to center and prioritize healing and liberation. We know that disabled neurodivergent folks are 16 times more likely to die in a police encounter. We know that over 50% of folks who are killed by police are disabled, particularly Black and Indigenous folks. And with this, I just want to uplift the Black scholars and organizers that I've learned from, Talila Lewis, Dustin Gibson, Aza Al-Taraifi, Imani Barbarin, Leroy Moore. Definitely encourage folks to check them out if you don't know of their work. But yeah, I just, again, want to uplift what Stella said about how we have to contend with the history of psychiatry, the history of mental health care, and those roots. Why were they built? What is the original purpose? If we look at the report, the Virginia Central Lunatic Asylum for Colored Insane in 1870, they were writing in their charts that the cause of psychosis was freedom, Black folks not wanting to work for free. This is the history. Stella mentioned drapetomania. I also want to uplift excited delirium, which is a term that has no medical grounds or basis, but is consistently used for neurodivergent Black folks who are murdered by police. We've seen this with Natasha McKenna. We've seen this with Elijah McClain, essentially blaming these folks for their own deaths because they are neurodivergent or mentally ill. The term is excited delirium. Basically that they got so worked up and so excited because of their mental illness that they, had a heart attack and died, and not wanting to point to what has happened to cause that. We see this with, there are studies that show that young Black boys may have the same exact symptoms as young white boys, yet the Black kids are diagnosed with oppositional defiant disorder, and the white ones are diagnosed as autistic. And we see how that plays out for folks. So for me, I'm thinking a lot about how ableism is really the foundation of every system of oppression, and ableism and racism work together in a very specific and intertwined way for Black disabled folks that that we can't look at that separately. It has to be looked at collectively. And this is something that Talila Lewis, TL, talks a lot about in their work. So I think my last point that I want to make is just that we have to, if we are white and doing this work, we have to be partnering with, centering with, uplifting the initiatives and goals of Black disabled organizers and organizations. For example, folks are saying, you know, registries, not okay. We don't need, police don't need a list of who's autistic and who isn't. Police training doesn't work. We have to stop highlighting that as a solution. And when folks say that over and over again, we have to listen to that and center that in the work. So yeah, I'm gonna stop there.
Thank you, everyone. And I really, I'm so appreciative to really ground, you know, this conversation in that, in the Black Lives Matter movement and centering Black folks. And I'm like so glad that this event is being recorded, so I can like come back, because like my brain is just like boggling all around, and there's like so much happening. And so, you know, I really want to get to a question that I think that a lot of folks are thinking about. And this is for everyone. How do we take what you're doing and use it to inform things on a national level? Like what can we do to make this something that is nationwide? And you know, what is your vision of that? And if you don't have a program you're working in, what is your vision of that? So you know, this is a question for everyone. So does anybody want to kick things off?
I mean, one of the things that is a significant barrier for nearly every community is that funding. You know, where do you get that seed money to get this thing started? Everybody wants to hear about, okay, you know, how much is this going to save us? What's our return on investment? You know, and it's this you know, perception that it's capitalist systems that are going to, you know, bail us out, right? You know, that whether it's reliance on, you know, the nonprofit industrial complex, or, you know, looking to create a municipal program that's going to go out and do these responses. You know, I think we have to recognize that funding is going to be a barrier. And so something that could help nationwide is talking to your local electeds, you know, at the federal level to support passage of the Cahoots Act, which was introduced to Congress just a couple of weeks ago, and would provide that kind of pilot funding for communities to really, you know, be able to implement this programming without having to, you know, empty their own coffers right away. But, you know, at the same time as we talk about doing this thing on a national level, we need to recognize there isn't going to be one single approach that's going to work in every single community. You know, as we talk to other cities that want to look to replicate the Cahoots model, if that's what they think is you know, going to best serve their community, you know, we are constantly saying, okay, this needs to be something that's informed by the folks that you want to serve. This needs to be a program that's designed by your community, because that's who it's serving. We can't pick something up that's been working in the very white liberal West Coast college town of Eugene and expect it to have the same results in Cincinnati or Tampa. You know, so as we look at really changing the landscape of public safety, of creating crisis response systems that are not a part of those, you know, existing systems of oppression and marginalization, we need to recognize that there isn't going to be one size fits all approach that's going to make this work, that every community is going to have to build something and design something that's unique to that community's needs if we're ever going to be successful in the types of change that we're talking about.
Just want to second everything Tim's saying. I think, yeah, funding is a big part, and we don't want to get into the mindset of, does this new intervention save us money? That's a losing battle. I saw that with Housing First, where initially you get Republicans on board by saying that if we give this person who is a high service utilizer housing, then you'll save money. Well, it might work then, but what about giving other people housing? You've already given up any sort of moral political argument for why that matters to just making it about money. And I think an important thing for us all to contend with is that even if we defund police, that money is significant, but it's still not going to be enough to do the kinds of things we want in the world. And so we have to get out of this tax neutral frame where it's just about taking money from the bad things and putting it to good things. We have Jeff Bezos, we have billionaires. We should be talking about taking a lot of their resources and giving them to other people. And so when we have to get out of this mindset of just, yes, defund, please reallocate resources, but that won't be enough. We have to look into other ways of getting revenues through taxes and other kinds of mechanisms.
I would say on a micro level, right? Like, talk to your neighbors, say hi, get to know them, right? Utilize the frameworks that exist on your block. You know, if your neighbor's the painter and you need some painting, like, holler at your neighbor first before we call the corporate, corporate painter folks, right? I think that one of our best tools is relationship, right? If we begin to build those relationships across the fence, that eventually we will not need, right, outside intervention. And also, if you're a healthcare worker or a mental health care for folks, right, or if you're in school, actively decolonize your practice. I've been a nurse a long time, and every now and then I got to check in with myself and be like, why don't I like this particular set of patient, right? The drunk entitled white guy, right? Like, I have to literally take a deep breath and treat him the exact same way that I would anyone else, because that is part of decolonizing, right, our practices, like identifying those biases that we have within ourselves. If you are in the state of California, AB 2054 has passed Senate. This will take tax dollars, right, and allocate them to community first responding programs. So if you have the time, tweet Gavin Newsom, tell him to sign it. For some reason, he wants this bill under the Department of Corrections, right, which is against everything that the that the bill is kind of outlining. And then also when we talk about, like, how do we solve mental health crisis, how do we solve homelessness, substance use disorder, right? Practical solutions work, right? We solve homelessness with housing, right? We solve mental health crises by providing mental health care. Right? So as you're going about your day and you're talking to folks and you're decolonizing your practice and you're talking to your neighbors, if you find someone who has some pen power in their hand and they're like, what do we do? Talk practical solutions, right? And then also, I know that there's a lot of conversation around, defunding the police. We have to talk about, like, what that really means, right? Like, how much do officers make? And if we equate that to how many resources, right? Even to the one officer, right? If the officer makes $80,000 a year, you can employ 2 mental health care workers for that amount of money. They deserve a lot more, right? But that's 2 folks, right, for the price of 1 man with a gun, right, who actually isn't going to fix the problem. So talking about the defund the police conversation in a way that's tangible and in a way that makes sense, so that as those folks who aren't so powerful to it can kind of understand, like, where we're coming from when we say these dollars would be better used in other spaces.
Thank you for that, Asantua. I definitely want to uplift the just kind of notion that, real safety does not exist in the context of, like, liability concerns or constant surveillance and constant evaluation. As Asantua said, it exists in relationships. And we know that, like, there's data that shows that folks who are experiencing domestic violence or who have just experienced a sexual assault, the vast majority are not going to turn to the criminal legal system, to outside folks. People are going to reach out to folks in there that they feel safe with, that they have comfort with, which is why, tools like pod mapping by Mia Mingus, the Bay Area Transformative Justice Collective, such an incredible tool to figure out who is in my pod, if I'm experiencing harm, if I'm causing harm, who can I call on? Who are some movable folks that I need to actually put some effort into building relationship with so that I can, have them in my pod, building care webs, building complex safety plans. Like I have Stella's crisis plan. Stella is going to have mine soon, working on it. But actually share those documents with people so that people in your life know how they want to be responded to if they enter into a crisis. And I think I also just want to add, like, this is possible. I work with so many folks who, because of the professionalization of what's happened, we have inherently lost the ability to respond to conflict, to anything really in community. We outsource, everything gets outsourced and privatized and monetized. And we inherently have these skills and the capacity and the capability to respond. Learn about de-escalation, reach out, read, study. Like this is as much about like learning skills as it is about political education. They cannot exist without each other. It has to be happening together. We can learn about this and become better. And also just knowing like, nothing about us without us, right, is a long standing motto of the disability rights independent living movement. So thinking about how we are the experts of our own body minds, and folks who are in this to support us, whether you're a social worker, regardless of your politics, you always need to defer to us. We are the experts. And whether that means, being really clear about what your reporting requirements are, so that people can make informed decisions, right? If you're operating a crisis line and you engage in active rescue, be clear about that so folks can decide how they want to engage with your services. So I think, I want to highlight what folks have said about, a lot of this is about really shifting the problem elsewhere, disappearing people, so that we don't have to deal with them. And we need to unlearn that and unlearn what we've known and heard our entire lives and been socialized to understand that disabled people, mentally ill folks, neurodivergent folks are burdens. Like we are not burdens. We are deserving of love, care in our communities. We don't need to outsource it. And that doesn't require just changing one thing. As folks have said, it's not just about defunding the police. This is about radically shifting our relationship to everything, which also requires dismantling capitalism. Like this is just, it's a lot of moving pieces that have to happen together. And one thing is not going to solve it all. And we need everyone to be working to create those solutions. It's not just going to be one program. It's not just going to be cahoots. It's not just going to be one thing that happens. We all have to be playing a part in building the world that we want to see, that folks want to live in, that provides that compassionate care to really help people in the way that we want to be helped.
I would love to jump in if there's still time on this question. Noah.
Yeah, just a couple minutes, just like
okay.
Maybe 2 minutes. Yeah.
Awesome. Okay, cool. Yeah. Really love what folks have said in response to this question. I want to echo Asantua, what you said about like relationship being our #1 tool. And I utterly agree. I think the first thing I would say in terms of like spreading this work nationally, internationally, is that we need to really evolve back into actively our interconnectedness and like fundamental like communal nature as beings. Like that is what we need. And along with that is using peer support models as wisdom to look to in teaching ourselves and modeling for each other how community can look, because peer support is largely about like using your lived experience as well as like your increasing empathic skills in life to like support one another in mutuality. So I think it really is like the crux of like what community kind of means. And so like Steph mentioned earlier, the notion of peer support is like an abolitionist tool, because it is something that like as it spreads and spreads and spreads, like we will not need these systems of control and correction that we feel that we need now. And I think when it comes to like community care, I think it's important for us also to keep in mind like care has to mean like meeting people's needs on their own terms. And a lot of folks have asked in the chat, like, what do we do in situations where someone is like rejecting care that I feel that they need? And I think it would be great if like we could speak to that a little bit later on, if possible. There's so much to say there. I utterly believe that like a world in which like all care is like actually care, by which I mean that it is on the terms of like the people receiving it and it feels like care to them, as well as like a world in which we don't do things non-consensually, like there will be so much less suffering and like fewer crises. Yeah, I think that, I don't know, that becomes a question. That question comes up a lot around how do we, what do we do in situations where someone like doesn't have the insight or something? I think there's so much there. And I still think that like consent has to come first. And so I think doing that work internally and in our communities to like decolonize ourselves, like Santua said, like decolonize your practice, learn about crisis de-escalation, as Stephanie mentioned, like do that work and that reading around transformative justice. And like if you are a practitioner, a medical practitioner, like holding yourself and like colleagues accountable to harm and abuse that happen within medicine, because I think that's something that is largely an issue in this conversation, is like doctors having like impunity. So I think, holding selves and colleagues accountable for harm as we decolonize ourselves, learn from people with lived experience, spread peer support, really go back to our like communal nature as human beings. And then also I'm just so excited to keep seeing like local mobile crisis responses that are independent of the state popping up more and more around the country. And I think that eventually like that has the potential to really like ultimately create like a web of care that will evolve us out of our current state.
Thank you so much, Stella. And I mean, I feel like you kind of already answered this question, but we had someone from the audience who had a question. How should those social justice oriented students in social work school or medical school strive to reconcile being great clinicians or social workers with police abolition? Is it possible to have both? So what about the social work students? And there's a lot of social workers who are also on this call as well. So like, how do they reconcile being part of this system? Is it possible to have both? Anybody can jump in.
I'll jump in. I think it's really hard. I think because, as many people have mentioned in the chat, the way in which there are liability standards. If you don't report certain things, you might lose your license. Like that inherent structure sets things up to dismiss the patient as the expert, right? There's always this inherent power dynamic that's really, really difficult. And I know I've talked with a lot of social workers who like have lived experience and feel and identify as peers, but are very discouraged from sharing that in any like professional capacity with folks, which, for me, the best experiences that I've had with mental health professionals have been folks who are open to talking about their experiences, being incarcerated, being pathologized. Like I need that in order to have a relationship with a professional. And I would really encourage folks to push the boundary on that. I already mentioned being very, very clear and upfront about what your reporting requirements are. I've worked with folks who hold a lot of space to talk about suicide and suicidal ideation and recognize the difference between having suicidal ideation and having the intent, the means, and the plan to actually accomplish that suicide. And if you don't hold space for that, people are not going to be honest, or are going to be terrified to open up. So I think it's really on you as a provider to be very, very clear about that, and to offer different solutions to folks. If you want to talk about something, maybe word it in the third person or whatever that looks like, to really establish those guidelines and those boundaries. I also think you have to be aware of the issues within your profession. Like, it's it doesn't help anyone to say, well, I understand, and I do this in my work. It's the system. It's a systemic problem, which means that your individualized desires or how you approach it is not enough. I think, I just was speaking to a social work student who was like, we don't ever talk about disability, and they're pushing to bring in disability justice organizations and folks to speak to social workers. Like, you need to be uplifting actual people with lived experience, again, in the classroom, in settings. So inviting, folks to come in and talk. Really, I think my main word of wisdom here is to be very honest and open that the field and the profession has a lot of issues, and that we need to be including peers, again, in the solutions and the work that we're doing, and recognize the limitations of your profession, and where those boundaries come in and where they lie.
If I could add, I wrote down a few things. I would say question everything you're learning, absolutely everything, with the understanding that all of our practices around medicine are just steeped in white supremacy, right? And also challenge the idea of whiteness and maleness as a normalcy, right? And that everything that kind of diverts from that is abnormal. I think that's one thing as a Black woman going through nursing school, I was like, damn, I'm just gonna die. Like, I'm just gonna get everything. You know what I mean? Because the framework is, I'm 50% more likely to lose a child, right? With no other explanation other than I was born female-bodied and in Black skin, right? So just challenging that white maleness as a normalcy. And then also there's an entire movement around dismantling the DSM, right? I think it was Stephanie who brought it up, how young Black males are being diagnosed with this oppositional disorder. Yet when, white young men have the same behavior, right? He's still a well-meaning child, and blah, blah, blah. When we think about Dennis, Dylan Wolf getting McDonald's, and, Antonio Thomas being murdered, right? And that thing, right? So dismantling and at best decolonizing the DSM as you're, going through your practices, just kind of through your studies, just kind of understand that this practice you're studying is steeped in white supremacy, and we have to challenge it every single time it shows up.
Thank you, Asante. And I'm looking at the time, and there's just so much to talk about. I wish that we could spend another half hour just talking about other stuff. But I think that one of the things that we had an audience question asked was, and I think maybe someone has already touched on this, but maybe we can kind of just bring it up again. What about the psych hospitals? Like, what happens to psych hospitals, and what does that look like in this new vision of mental health care?
I can start. I'd love Stella to jump in. As Noah mentioned, Stella and I just co-authored a piece on abolition must include psychiatry. I think they're gone. I don't think they're here. Neil talked a bit about deinstitutionalization and the various ways in which it was, sort of realized. Some state hospitals closed, but we still have a thriving system of incarceration. We still have asylums. They haven't gone anywhere. And I think, Stella and I have talked about this, about how there are parts and aspects to psych wards, right, that we might want to take out and repurpose and figure out why that helps some folks. Like, you know, I've talked to people who say like the structure of it, being able to go somewhere else and have structure. That's really helpful for me. Well, amazing. Folks have done incredible work with peer respite centers. There are about 14 in the entire nation. They're completely underfunded, and they're amazing. There's been a lot of data that shows that peer respite centers, which if y'all don't know what they are, they're basically homes that are, you know, non-medical centers that are staffed and led by people with lived experience who are providing these like short-term stays, and really socially minded, healing-centered, trauma-informed aspects of care. And, you know, we need to have those everywhere. And, you know, we need to figure out what aspects of, you know, of these institutions may be helpful in certain capacities, take it out and repurpose it. But things need to be voluntary. We're getting rid of restraints, chemical restraints, physical restraints. This loss of autonomy and self-determination is really at the heart of this institution. And I really believe in a future and a world where they no longer exist under any name. The ability for someone to put me in an institution against my will no longer exists.
Yeah, just jumping in, fully second everything that Stephanie mentioned and described. As I've made very clear, I'm an abolitionist. I utterly believe that psych wards need to be abolished completely. Like Steph also said, the necessity of not like repurposing them under a different name is, you know, extremely vital. Goes absolutely hand in hand with the abolition of prisons, and even the call to defund the police. And I do think it's great calling attention to the alternatives that exist right now, and what we can do right now as we simultaneously work towards abolition, which I think have to be like sister processes. But of course, people still have crises and like need their needs met. Respite centers are amazing. I think such an excellent alternative. There's a place called the Living Room in Framingham, Massachusetts, for folks who live in Mass or in the Boston area. Very cool, like innovations happening in alternatives, in spaces that feel safe for people to process what they're dealing with, in spaces that feel healing. I think we also can't underestimate the efficacy and power of like self and community created spaces that make us feel good. Like personally in my like crisis plan, like something that I mention is that if I feel like I'm in crisis, need to be in a space that like a garden or you know, a particular room or apartment of a friend that I know like feels sensorially like good and nice for me. I think in addition to that, like a lot of folks, I don't know, experience the need for like creative expression when dealing with crises, or maybe their need centers on like discussion, talking to their friends, talking things out, processing. I think like naming for ourselves like what would help me, what helps me feel better, and then like using that and the notion of like when people are in crisis, it's because like there are core needs often. I would say typically, yeah, core needs that are not being met, and like naming like, okay, so if like folks have core needs that aren't being met, how do we on, of course, a systemic level, but also on a micro level, like meet those needs? Like, you know, where is like loneliness playing a role in this person's crisis? Where is like a recent trauma playing a role? Where is not feeling heard and needing to be heard by their friends more? You know, so all of these things I think can help us continue to design healing spaces that are not psych wards, and peer respites are a great like jumping off point for that design.
Yep. All right, y'all. Well, thank you so much. Oh my gosh, like I have chills right now. I feel like we just like cast a spell into the world, and like this is like the spell that's gonna magically like dismantle oppression, and like this is just part of like that magical spell. So Oh my gosh, I'm just like enthralled with all of your work and your answers today. I really thank you for bringing all of who you are to this space. So we are just at the top of almost to 8 o'clock, and we actually have some two folks coming together who are going to join us just for a few minutes to talk about their work they're doing. They're from the Correct Crisis Intervention today, CCIT, and it's a New York City-based organization doing some advocacy work. So we're going to welcome Carla Rabinowitz and Allison Weiland to just speak briefly about that.
Thank you so much for including me. This is Carla Rabinowitz. I'm the project coordinator of CCIT NYC, Fighting to Transform New York City's Response to Mental Health Crisis. For all the reasons you mentioned a few years ago, we came up with a model that has one peer de-escalator and one EMT responding to crisis calls. We picked two of the places in New York City that have the most number of calls, and we are working to get that funded. We know that Cahoots has been around, but Toronto, Los Angeles, Portland, San Francisco are all going to models of one peer, one EMT, and one clinician. A lot of people are saying this can't work in New York City, but New York City already has a model called Transitional Services of New York LEAD model, where they have one peer and one clinician. They've handled 3,000 calls. Their response time is 6 minutes, and only 3% of their calls have to take someone to a hospital. That's very important in our model, that we don't want hospitalizations. We don't want arrests, we don't want police, we also don't want hospitalizations. And the other thing is we define peer broadly, very broadly. So maybe someone else can talk on that. I know I don't have much time, so if you're interested, our website is ccitnyc.org, ccitnyc.org. If you like the model of having a peer de-escalator and a peer de-escalator and an EMT, go to CCIT events page and take some action. If you want to read our proposal more, go to CCIT and hit the proposal page. And I just want to say thank you for your time.
Hi, thank you everyone. I'm Allison Willens. They, them, long brown hair, red collared shirt, lavender plant, book about mushrooms in the background on Lene Lenape land. I'm going to talk fast and reach out if you want to talk any more about any of the topics I'm going to raise. I'm thankful for IDHA for having us, these panelists who have all personally inspired a lot of my work. So I am a harm reductionist, a prison abolitionist, EMT, and peer responder. I participated for 5 years in a crisis support model for people who use drugs that is similar to the CCIT NYC model using EMTs and peers. Through that work, we kept thousands of people from going to the ER or jail and avoiding transport at all. We need to decriminalize all altered states, whether induced through a drug or endogenous. Altered states are often of a medical nature. Overdose is preventable. All overdoses are preventable, and over 500,000 people have died of overdose in the United States alone in the last decade. And so, we need to fund harm reduction response for that, but we also need decriminalization and safe supply, right? People only die because the drugs that they're taking are poisoned. And that's something that's very preventable. If you went to the pharmacy and your drugs were poisoned, you would be pretty upset about that. It's a very reasonable ask for us to be able to provide that to people. So anyway, additionally, the knowledge that I have comes from the wisdom of people who use drugs in these communities. It's a harm reduction model. And some of the concerns that have informed that are concerns about people who are criminalized when they access these kinds of state systems. So like the larger conversations that we're having around whether pursuing a legislative model or even funding models outside is around, data sovereignty, not having surveillance be a condition of receiving resources. I want to add that many people who use drugs are neurodivergent and are people who are using drugs within that context. We need solidarity. There are no single issues, people, and you can't solve one at a time. I want to add that the original ambulance service was actually invented by Black folks who were self-organizing in Pittsburgh to help their communities. We're far from those radical roots, but we can get back there, and the work of Project Let's is very inspirational to me in that regard. I want to talk about oversight versus over-credentialing. Because yes, I want to uplift my lived experience as a neurodivergent person, but realize that that's, and talk to healthcare providers, but realize that that's traumatic for me and exhausting. And we should be paying peers for that, right? Like if a system is complicit in violence, you're not doing people with lived experience a favor by including them. They're doing you a favor. Compensate them for the time to talk to you and the time it takes for them to recover afterwards from the ableism that you have not yet learned to unpack. If someone is resisting care, it's not the right type of care. You're not paying enough attention to what they need. We also need a labor movement for healthcare workers, whether they're peers or EMTs or nurses. Set and setting matter. Most ERs I've been to are designed in a way that exacerbates the stress due to sensory sensitivity. We got to replace these fluorescent lights, get some dimmers or something. Seriously, we need one-to-one attention. Stop. We need to have, yeah, and as I said before, stop requiring surveillance as a condition for receiving resources, especially in a context in which reparations are really in order. You got to turn that surveillance around on the system itself, be transparent about everything about your process, allow yourselves to be held accountable. Neurodivergent people are not asking permission for agency. We're telling you that we have it. We are organizing the support systems that allow us to self-determine. We are reckoning with the violence against us. You need to stop killing us. We can't delay these kinds of solutions because of public opinion. We have to commit to educating the public about all of our issues. And we have to make it sustainable to iteratively build a world where it's safe to fall apart. Systems that are not ableist outcompete and outproduce ableist ones. People who are, you don't get to make it out of this life without being disabled. We're early adopters. It's your best interest to learn from us. This idea of like, oh, we're going to solve mental health crisis, we actually might not. There might always be mental health crisis. My goal is actually not to eradicate that. It's to provide these safe containers. We have to stop pretending that we can have perpetual adolescence and understand our role in the larger ecology, the role of death and resource reallocation in that ecology. You can study fungal networks about this. At lower stages of complexity, emergent organizing is most efficient. At higher stages, there needs to be mediation between those emergent nodes while acting autonomously. Reliability, assuming responsibility, self-determination is a participatory process. So the shadow of being free is that we're also responsible, right? So there's not, we have to put plans in place to de-escalate crisis before they get to an emergency point. But a lot of crises, an emergency response isn't even necessary. But when it is, we actually do have to talk about liability. We actually have to talk about who is responsible. Is it the owner of the space? Is it the person? Is it the responder, the city? We need to negotiate these things and form new agreements. And I want to end by saying, I want to challenge us when we say, oh, we're not ready for that yet. We have to check ourselves and our roots. Are we coming from this survivor perspective, or are we coming from a provider perspective and our own resolved feelings about the complexity of our moment and our roles in these systems?
Thank you so much, Allison.
Anyway, yeah.
Yeah, thank you so much. I really appreciate you coming in, and really make sure you check out this organization. All right, we only have a few more minutes. I really just, before I pass to Jesse, want to plug that this was a free event, and IDHA really tries to make sure these events are free for everyone. You can donate to this event and make sure that more just awesome events like this are happening. We want to make sure we pay, we're paying all our panelists well, and we had to upgrade our Zoom level for this event. So, I just would appreciate that, people, if you are able to support, just throw some funds our way. And thank you so much for everyone who's participating today. I'm going to pass it over to Jesse to end us.
Awesome. Thank you so much, Noah. And the hugest of heartfelt thanks to everybody. Could we actually have all of our panelists turn their videos back on, and our interpreters, just so we can see everybody's faces? This was an incredible conversation. I am moved almost to tears over here, and I'm really humbled by all of the wisdom that we've got in this Zoom room, including everybody in the chat, which we will save. So yeah, quick note on the follow-up, we will be sending everyone who registered the recording, as well as the transcript from the closed captions, the anonymized chat, and all of the links and resources that have been shared. And another huge thank you to our incredible ASL interpreters. I don't know how they've kept up with some of this conversation. Thank you so much. Also to our closed captioner. And before we go, I have one last announcement from IDHA, which is that this event has been in the works, being organized for a couple of months now, and really with the goal of building to IDHA's fall training series. So actually, as of now, 8:00 p.m. Eastern, We have just launched our fall class online, so I'm going to stick the link here in the chat. It's called Healing Systems, Models, Tools, and Strategies to Transform Mental Health Care. And essentially, you know, a response to the fact that so much of the training that folks get when they're entering the mental health system, or if you're just supporting people informally in your community, we tend to focus on the individual and often, of course, pathologizing the individual. But this class is really going, or this 3-part series is going to focus on the systems that intersect with our mental health. So the first class is going to be about kind of macro systems of oppression and how they intersect with mental health. The second about kind of relational systems, including a deep dive into open dialogue. And finally, the last class will be about internal family systems and somatic practice, and about our embodied transformation. So check out the link. I'll stick it there. Actually, I don't know if I stuck it there before. Now that is in the chat. So yeah, registration is open. First class is October 24th, and we'd love to have as many of you join us as possible. So yeah, I guess to close it out, does it, Noah, do you have any last words? Thanks everyone for being here.
Y'all are amazing, and just take care of yourself in these hard times, and we will win.
Awesome. Thanks, everybody.
Thank you.